there should be a representative at the regional office to lead the behavioral health messaging that goes on. And so I sit there in Philadelphia in the Public Ledger building, right down the elevator from Tom McClellan and across the street from the Liberty Bell. I sit there with about 300 federal employees, half from CMS, one from SAMHSA, and then some from, in descending order of numbers of folks, HRSA, can I use HHS acronyms and be okay? HRSA, ACF, what used to be AOA, Administration on Aging, now Administration for Community Living, and then we also work fairly closely with the Regional Health Administrator who reports to the Assistant Secretary for Health, dotted line to the Surgeon General, real public healthy kind of guy. And then we have a regional director there who directs nobody among the octaves. However, she is the political appointee of Secretary Sebelius and has a direct relationship mostly with the governors, legislators, and also the insurance commissioners. So I am in the regional office in Philly so that when there is a conversation about health, behavioral health is at the table. And so that's my charge, and my first act as regional administrator was to convene each of the senior staff from those operating divisions and staff divisions that I just mentioned and our state counterparts. So we invited to one meeting, never before done, and I was warned on many levels to never do this, including by people in my direct chain of command. We invited the behavioral health directors, the departments of health, Medicaid, aging, primary care, you name it, they all got invited. We had 50 people. We had to do a VTC because of the scandal in Las Vegas instead of an in-person meeting. But it was really quite effective, and I also invited the heads of NASDAQ, NASHBID, and also Ron Manishai who represents the counties. And so my offer to you is that if there's something I can do for you to connect you with any of those folks, that's one of my jobs. An example that relates to what Tom was talking about earlier, because we really have all our focus on ACA and especially on parity. SAMHSA is the big cheerleader for parity, even though we have no authority in the matter as far as enforcement, is that I have convened the insurance commissioners and behavioral health authorities in 5 of the 6 states in the region, and in most cases it was the very first conversation like that. And it was very revealing about how important it is that behavioral health be at the table where policy decisions are made. So I would just let you know that's the kind of thing that I can do. I can convene people that nobody thinks would normally convene in order to get the message and policies of behavioral health moved forward. So there's a lot of other things that I could say and do in my remaining, it's probably about 2 minutes. Oh, I have 5 minutes left. So what I decided to do was, there's 2 things that I think I want to get through. One was the comment from our wonderful primary care physician. I heard you tell someone you were from Boston, my hometown. So here's her quote. This is the most often heard issue described that I have heard in my integration work, which has been a big part of my job for the past 2 years. We don't know what to do if we get a yes answer to screening questions. All right, so I think that sort of focuses our mission, and my challenge in hearing research is how do I take all this wonderful research and have the people in the field feel like they know what to do with this in a practical way. So last Friday I spoke to a group of 800 social workers, and I tried to get sort of in the weeds with them enough that they would really feel comfortable giving me feedback and telling me their stories of things that needed to be solved. And unbelievably, I got 2, and they sound exactly alike. And I think what I'd like to do is just tell these stories as food for thought as you continue the rest of the conference and as you continue to provide leadership in your various roles so that we can improve our systems of care. This one, I enjoyed hearing you speak at the conference. It was helpful to see the faces of the administrative people who make services a reality for our clients. I would argue that we are not the ones that do that, but anyway. I am the social worker for X prenatal program at such and such a hospital. My concern is for the patients who lose their medical assistance soon after their 6-week postpartum appointment. Frequently, this is a time when we determine that they are experiencing some level of postpartum depression, but no longer have coverage for counseling or meds. I was wondering if there is a way to extend their coverage or if there are other resources that are accessible for them. In recent years, our clientele has included more and more patients who are on Suboxone or methadone, and they are at greater risk for postpartum depression, which can lead to relapse and all of the other complications. Thank you for your attention to this matter, exclamation point. So I've already engaged. The first thing I do with these is tell the state and try to get them engaged and then get out of the way. So I'm not proposing to you that this is my job to fix this problem, but if I know what's happening in the field, the other half of my mission as the regional administrator is to find out what's going on and feed that back up to Pamela Hyde and everybody in between, and to take Tom's comment seriously about, you know, here's something that SAMHSA does that we do not feel is in keeping with the science and interpretation of how things should be. My other role is to find out what's going on, find out what you think, and find out what SAMHSA can do better, and get that information back up to our policy makers. I'm in the Office of Policy, Planning, and Innovation, and so that is my commitment to you, that if I hear something, I will try to do something constructive with it. Now, I don't know if I have time for this second story. It's really quite compelling, so I'm gonna give it a shot, because I heard some oohs and ahs with the first one. I'm writing to you because I saw you present last week, and I would really like to thank you for what you are doing and some of the barriers that I am encountering and wondering how you might be able to assist me and direct me in the right direction. I am at the such and such outpatient program. I'm a social worker with the such and such health system. My position is working with the super utilizers, high utilizers of the emergency room and inpatient. She didn't finish that sentence. And this is super utilizers, another hot topic, right along with what you were saying. I follow them in the home, in community, and assist them and follow up with recommendations from the hospital, primary care physicians, specialists, etc. I also focus greatly, this is cute, I also focus greatly on Maslow's hierarchy of need and make sure that my patients all have their basic needs met so that they can focus on their medical and mental health conditions that are seriously impacting their quality of life. I'm writing in regards to some concerns that I have recently discovered through my position with the hospital. Due to the current, now this is precious, this is unbelievable that she interprets it this way. Maybe it's true. Due to the current changes in the healthcare system with the governor asking each emergency room to focus on reducing non-emergent visits in order to assist patients in properly utilizing the healthcare system, we are trying to educate the community about proper use of emergency room. Oh, 1 minute to go. And so it goes on and on, talks about a halfway house and a lot of the specific types of issues that the other social workers was referring to. And I love the last paragraph, and I think it really brings into focus what our work is about and why it is so important for your individual leadership to have an impact on the field. If appropriate coordination of services were done prior to an individual being paroled, we could avoid this delay in medical treatment and we would provide more efficient care for the men who reside at such and such a halfway house. I am requesting that there be an opportunity for discussions on how we have more efficient coordination for these men so that they are paroled with a 3-month prescription for all life-sustaining medications. So it's a microcosm of, I think, all the things that we deal with. And I'm not sure how to get the research to fix the system, but I appreciate everything you're all doing in that regard, and I look forward to hearing from you how SAMHSA can do a better job going forward. Thank you.